What's the topic today? Right. So we'll talk about diarrhea today. Uh, Basically we classify the diarrhea into two main categories. One is acute diarrhea and other is a chronic diarrhea. This classification is clinically very important. Any diarrhea which is less than 2 weeks in duration is acute. So less than 2 weeks of duration for any diarrhea is usually taken as acute diarrhea, and more than 2 weeks is taken as chronic. Now, any acute diarrhea which is less than 2 weeks is infection unless proven otherwise. This statement is very important. Any acute diarrhea, even if it's even if a patient is known to have a underlying diagnosis, for example, patient has inflammatory bowel disease, ulcerative colitis, or Crohn's disease, or any other underlying pathology which can cause diarrhea in that patient. Even then, if the duration of the diarrhea is less than 2 weeks, it's acute diarrhea, it is infection unless proven otherwise. Unless proven otherwise means that you have to either treat it as infection or make sure that you have excluded the infection properly with thorough investigations. For example, patient has a known case of ulcerative colitis, and they come with the diarrhea which is less than 2 weeks. It is infection, and we treat as infection or we exclude the infection. Unless the infection is certainly excluded, the treatment for the infection is started from the beginning, and once the infection has been excluded, then the antibiotic can be stopped. So this is an important rule. Acute diarrhea, when we say it's infection can give you any pattern of the diarrhea. I will come toward the end, toward the end of the lecture, I will tell you those patterns, how the infection can explain those different patterns. But let's talk about the chronic diarrhea, which is often a problematic diagnosis. Okay. Now, the chronic diarrhea, uh, there are different types of the chronic diarrhea, but one of the important thing we need to explain is clinical findings or clinical features of ileal pathology. That will explain a lot of things. Okay. So let's understand what are the clinical symptoms of the ileal disease. So ileum is the last part of the small intestine. It's the longest part of the small intestine, and the distal part of the ileum is the narrowest part of the small intestine as well. So whenever there's any pathology of the ileum, if for example there's an inflammation in the wall of the ileum, so it can include the lumen as well. So ileal diseases, they often present either with subacute bowel obstruction. Okay. So this is one manifestation. Second important thing is most of the ileal diseases, we'll talk when we go through the list, you will understand that most of the ileal diseases, they are transmural. So usually they cause adherence of the adjacent bowel loops, so they can make mass of the ileal matted loops. So the patient can have a mass right iliac fossa or in the periumbilical area. The third important finding of the ileum is that ileum is embryologically a derivative of the midgut. And midgut pathologies, they usually give either periumbilical pain or mid-abdominal pain. So ileal pathology can give periumbilical or mid-abdominal pain. The clinical significance of this embryological fact is that the lower of the pancreas is also a midgut derivative. So pancreatic pathologies can also give a midgut pain, and pancreatic pathologies can also present with the malabsorptive diarrhea. So this is where the confusion will start, ileum versus pancreas. So I'll explain it later, but let's complete the findings of the ileal diarrhea. The third important thing is our bile salts, they are absorbed in the ileum. So when there's a ileal pathology, when the mucosa of the ileum is not working, bile salts are not reabsorbed properly. So they will be thrown down into the cecum and the right colon. These bile salts, they cause irritation of the cecum and they cause irritation of the colon, right-sided colon. Remember, whatever liquid we take in the food, half of that liquid is absorbed by the small intestine and almost half of it is absorbed by the cecum and the right-sided colon. So when we're irritating the right-sided colon with the bile salts, so bile salts will stop absorbing that liquid part of the food which we take in the diet. Plus, because of the irritation, it will cause glandular secretions to increase. So this leads to a lot of water in the right-sided colon and leads to the watery diarrhea. So one of the finding of ileal disease is a watery diarrhea because of the bile salts malabsorption leading to irritation of the colon, right-sided colon. Now, if we give cholestyramine or bile salt binding resins to these patients, they will bind with the free bile salts which are not absorbed, and the irritation of the colon will decrease, and the diarrhea usually responds. So, chronic watery diarrhea, which responds to the cholestyramine, it is one of the indicator that this patient has a choleratic diarrhea, CHOLURETIC. Choleratic diarrhea means bile salt induced diarrhea, which responds to the cholestyramine, is a clinical finding in ileal pathologies. Next important point is B12 absorption is also happening in the ileum. So ileal pathologies, especially if they're long term, after the long duration of the chronic duration, they can cause B12 deficiency with macrocytic anemia, megaloblastic anemia, and peripheral neuropathy. So presence of peripheral neuropathy or megaloblastic anemia in a patient with the diarrhea is another clue that this is most likely an ileal diarrhea, ileal pathology. Okay, so I will summarize the clinical findings of the ileal pathology: small bowel obstruction, mid-abdomen or periumbilical pain, right iliac fossa or mid-abdominal small intestinal bowel mass, right? Choleratic diarrhea due to the bile salt irritation of the right-sided colon causing chronic watery diarrhea which responds to cholestyramine, and B12 deficiency causing megaloblastic anemia and or neuropathy. So whenever any of these clues are present, this is most likely an ileal pathology. Okay. Now, when the ileal pathology is involving less than 50% of the ileal mucosa, this is a rough cutoff value. It doesn't mean that 49% or 51% will make any difference, but just to roughly to give you a rough estimate, if the small ileal mucosa is affected less than 50%, it usually causes bile salt malabsorption, but it's not that severe that it will cause bile salt deficiency in the body. Okay, so there's a bile salt malabsorption, but there's no bile salt deficiency yet. Although the bile salt storage in the body will decrease, but there's no bile salt deficiency yet. Okay. However, when the mucosa involvement gets more than 50%, more than half of the ileum, now the bile salt storage in the body also declines to the point that it leads to the bile salt deficiency. So worsening of the ileal disease will cause bile salt deficiency as well, and this deficiency will cause fat malabsorption. Now the watery diarrhea, which was there because of the bile salt irritation of the right-sided colon, when they're not absorbed, now it will change to the malabsorptive diarrhea, which will become bulky and fatty and semi-solid. So in a patient with the ileal pathology, when the diarrhea changes from chronic watery diarrhea to chronic semi-solid diarrhea, it means the patient's ileal pathology is worsening, and now it's all progressing to the state that now the body has ileal bile salt deficiency. Okay, initially there's a bile salt malabsorption which reduces the bile salt storage, but not to the point that there's a bile salt deficiency. So patient doesn't have this findings of the bile salt deficiency. When the disease progresses more than 50%, bile salt deficiency starts due to lot of malabsorption, and now when there are not enough bile salts in the upper small intestine, fat malabsorption will also start and patient will have steatorrhea. So initially the diarrhea is chronic watery, which can transition to the chronic semi-solid malabsorptive type diarrhea, but that doesn't mean that the patient is improving. That means the patient is actually worsening. Okay, so these are the indicators of the ileal pathology. Now, the diseases which affect the ileum, they include, if you're working in underdeveloped countries such as Pakistan, is one of the first differential is tuberculosis, ileocecal tuberculosis. Second is tuberculosis, and third is tuberculosis. If you're working in developed countries like Western countries, Crohn's disease, second is Crohn's, third is Crohn. Then comes the TB, and then comes lymphoma, and there's some bacterial infections which can cause chronic ileitis, such as Campylobacter jejuni, or Yersinia enterocolytica, Yersinia pseudotuberculosis. They can also cause chronic ileal damage, right? So ileal resection will also give you the similar findings. So surgical resection of the ileum can also cause ileal pathology. All right. Now, when we talk about the chronic diarrhea more than 2 weeks, so first of one category of the chronic diarrhea is chronic watery diarrhea. Okay. Remember, the first and the foremost cause of chronic watery diarrhea is ileal pathologies, ileal diseases causing bile salt, malabsorption, which causes watery diarrhea due to irritation of the colon, of the cecum and the right-sided colon, and leads to reduced absorption of the fluid and increased secretions of the intestinal glands, leading to watery diarrhea. So chronic watery diarrhea, the number one cause is the ileal disease. Number two cause is villus adenoma of the colon. Okay, villus adenomas are usually quite large in diameter. Okay, and they secrete lot of secretion, so they can cause chronic watery diarrhea, but they're usually in either in the right colon or in the transverse colon. And the third cause of the chronic watery diarrhea, first is chronic ileal pathologies, second is villus adenoma of the colon, and the third is neuroendocrine tumors. So if the patient has a chronic diarrhea which is watery in nature, not semi-solid, which is watery in nature, it means patient has a chronic ileal disease. If it's not chronic ileal disease, then it's a villus adenoma of the colon. If it's not villus adenoma, then it's a neuroendocrine tumor such as carcinoid syndrome and VAPomas and other. So when you classify the chronic diarrhea, you classify them as is it watery diarrhea or is it non-watery diarrhea? If it's pure watery, then these are the causes. Now coming to the second type of the chronic diarrhea is blood containing diarrhea. Okay, chronic bloody diarrhea. Remember, whenever there's a bleeding almost always happens in the in a patient who has a colitis. Bleeding is very uncommon in the patient who have a small intestinal pathologies. Small intestinal pathologies, they're very less likely to bleed. Is the colon which bleeds more easily. So chronic bloody diarrhea is colitis unless proven otherwise. Okay, because the reason why the colon bleeds easily is because the colonic mucosa is thin and the vessels are very close to the lumen. Small intestinal mucosa is quite thick. There are a lot of villi and the vessels are deeper. And usually they don't bleed that often. Okay, so chronic bloody diarrhea is colitis unless proven otherwise. Now I will explain it a little bit more. Now colitis can be of different types, but there are a few important points to remember. Remember that the defecation reflex, that how the patient start feeling urge to defecate start from the rectal mucosa. Nerve endings are there. So if there's an inflammation or ulceration of the rectal mucosa, okay, patient will have a repeated desire to defecate. Okay, patient will have sense of incomplete evacuation. Patient goes to the toilet, when they come back, they think that they need to go back again. Patient has a burning and pain or discomfort in the rectal area when they defecate. Okay? This is called as tenesmus. So presence of the tenesmus in a patient with the colitis mean this rectum is involved. Okay. Now ulcerative colitis almost always start from the rectum, and then it ascends upward toward the left colon, transverse colon, and then the right colon. Crohn's colitis is most of the time rectal sparing. Excuse me, just give me a second. Sorry. Crohn's colitis almost always spares the rectal area. Crohn's involve the anal area, but not the rectal area. Okay, so rectum is classically spared in the Crohn's colitis, whereas ulcerative colitis almost always start from the rectum. So presence of chronic bloody diarrhea with proctitis or with tenesmus mean colitis which has involved the rectum as well. So that means ulcerative colitis comes higher on the list of your differential diagnosis. Okay. Now, and if the rectum is spared, there's no trismus, it's unlikely that this is ulcerative colitis. Okay, this is very, very important point clinically. So patient has a chronic bloody diarrhea with chronic diarrhea more than 2 weeks, there's blood in it, and there's tenesmus. That means rectum is involved. That usually means ulcerative colitis. Okay. Rectum is spared, that usually means ulcerative colitis goes at the bottom of the list. And then the other causes of the colitis, they comes into play. Okay. So this is the difference between ulcerative and Crohn's colitis. Crohn's colitis most of the time involve the right side of the colon, cecum and ileal area, but it can also involve the transverse, but is usually sparing the rectal area. Involvement of the anal canal is not a finding in ulcerative colitis. Okay. Anal mucosa involvement or anorectal fistulas, they mean Crohn's disease. Okay. Colitis can be infectious colitis, such as TB can involve colon and can cause chronic colitis. Okay. Usually when the TB involves the colon, it usually involves the transverse colon. Okay. Colitis can be ischemic colitis as well. So usually these patients who have ischemic colitis, they have other risk factor for the atherosclerotic disease, such as they have ischemic heart disease, they have stroke, they have old age, or they have atrial fibrillation causing thromboembolic disease. Okay. So they are at high risk of ischemic colitis. Ischemic colitis usually involve the watershed area such as splenic flexure, which is where the junction of the superior mesenteric and the inferior mesenteric arterial circulation is there. So junction areas or the watershed areas are the most commonly involved. They classically spare the rectum because rectum is quite vascular organ. So rectum is less likely to be involved in the ischemic colitis. Okay. So rectal sparing is more likely Crohn's or ischemic, but rectal involvement is more likely in ulcerative colitis. Okay. Now, the other types of the colitis could be radiation colitis, proctocolitis. Patient who has a pelvic tumors, radiation to the pelvis, or the abdominal tumors having radiation, they usually get proctitis or the colitis because of the radiations, and they bleed. They have chronic diarrhea, they have chronic blood-containing diarrhea. So they usually have a history of the radiations in the past. Okay. There's few types of the colitis which are histological diagnosis made on the colonoscopy and biopsy with the histological assessments such as lymphocytic colitis, collagenous colitis, microscopic colitis. These are different types of the colitis which are histological diagnosis. So chronic bloody diarrhea is colitis unless proven otherwise. It's very unlikely to have a small bowel disease, purely small bowel disease causing chronic bloody diarrhea. Okay. So the third type of the diarrhea, which is chronic malabsorptive diarrhea, right? I'll summarize them again. We have talked about the chronic watery diarrhea, which means ileal pathology, villus adenoma, or neuroendocrine tumor. Then chronic watery diarrhea, a chronic bloody diarrhea, which means colitis of any type. So we ask about trismus and see if the rectum is involved. Ulcerative colitis goes higher on the top, and if the rectum is spared, ulcerative colitis is less likely. We asked about the history of the radiotherapy in the past, and we also exclude tuberculosis as a cause of chronic colitis. Right? There's a very classic saying in a surgical book that if the patient has a chronic bloody diarrhea and the patient is younger than 60, chronic bloody diarrhea in a patient who is younger than 60, this is more likely to be ulcerative colitis. Chronic bloody diarrhea in a patient who is above 60 years of age is more likely to be ischemic colitis. Certainly the same thing, that age is a risk factor for ischemic colitis, atherosclerotic disease. The third category is chronic malabsorptive diarrhea. Malabsorption means, remember, whatever food we take, all the solid food is absorbed by the small intestine. S for small, S for solid. Small intestine is the one which absorb all the solid food. Okay. Whatever is not absorbed by the small intestine will go to the colon and will pass as such as a poop, as a fecal matter. Okay. Large intestine has no role in the absorption of the solid food. Solid food is absorbed only through the small intestine. So any small intestinal pathology can affect the absorption of the solid food, and the patient can have malabsorptive diarrhea. So malabsorptive diarrhea means there's lack of absorption of the solid food. That's called as malabsorption. Lack of absorption of the solid food is called as malabsorptive diarrhea, and that happens in the small intestine pathology. That doesn't happen in colitis. Colitis doesn't explain malabsorption. Colitis only explains diarrhea with or without blood, but it doesn't explain malabsorption. Malabsorption means this is small intestine. There are two assistants to the small intestine for the absorption. One is a bile salt, other is a pancreatic juice. So malabsorption can happen if the patient has pancreatic problem, if the patient has a cholestasis, when the bile salts are not reaching the small intestine, or if the patient has a small intestinal disease itself. Okay. Malabsorption, when the solid food is not absorbed, this will pass down into the colon and will pass as a large volume stool with lot of fat in it, which is called as steatorrhea. It will also have lot of proteins. Okay. Presence of the fat in the stool will make it bulky, greasy, and it becomes lighter and floats on the in the pan. Okay. And is difficult to flush and is difficult to wash. They find it difficult to wash because it's sticky, and they find it difficult to flush. It floats on the pan and is bulky, is semi-solid. Okay, and if you assess it, there's a lot of fat in it. So increased fecal fat quantity in 24-hour stool more than 6 gram is one of the indicator that this is malabsorption. Of course, it will have high proteins as well, such as fecal elastase will be high where they are not absorbed properly. Okay. So when we say there's a chronic diarrhea more than 2 weeks and it's bulky, this is semi-solid, there's no blood in it, okay, and this not watery, it means we're talking about malabsorption. All right. Now, malabsorption is either because of the cholestasis. If the patient has cholestasis, patient will have cholestatic LFTs, which means raised alkaline phosphatase and gamma GT. Patient may or may not have jaundice, obstructive jaundice, depending upon how bad is the cholestasis. If the obstruction is diffuse and quite extensive, patient can have high bilirubin as well, but early diseases may just have a high alkaline phosphatase and gamma GT. Biliary tract imaging will give you the diagnosis. Okay. If the patient has malabsorption because of the pancreatic pathology, such as chronic pancreatitis or pancreatic exocrine insufficiency, so usually because of the chronic pancreatitis, they have abdominal pain. They may have a pancreatic calcification as well. And the imaging of the abdomen can detect those calcification or the pancreatic atrophy or pancreatic inflammation. Patient may have a history of chronic or recurrent acute pancreatitis. Okay. Patient may have type 1 diabetes as well because of the significant pancreatic damage. This can also happen in patients who have a pancreatic surgery, such as patients with the Whipple's procedure and similar pathologies. Okay. So any pancreatic pathology can also cause malabsorption. So whenever the patient has a chronic malabsorptive diarrhea, the first thing is you ask yourself, is it a cholestasis? If there's no jaundice and if the biliary enzymes are normal and the bile ducts are normal, then you ask yourself, is it a pancreatic insufficiency? Okay. Usually that happens in chronic pancreatitis and is a painful. Patient has a pancreatic calcification. Fecal elastase is one of the very good marker for the exocrine pancreatic insufficiency, and fecal elastase level will be high. Okay. Now, if it's not pancreas and if it's not this bile, then this malabsorption is the small intestine. Okay. You can divide the small intestine into three parts: duodenum, jejunum, and ileum. Remember, all the divalents, all the ions which double charge, such as magnesium, which is 2 plus, calcium, which is 2 plus, they are usually absorbed in the duodenum and the upper small intestine. Iron has a 2 plus or 3 plus. Okay. So they are absorbed in the duodenum and jejunum. Okay. Proteins are absorbed in the mainly in the jejunum area. Ileum usually is not meant for the protein absorption. Protein absorption is rapid and it usually happens in the upper small intestine, duodenum and jejunum. Fat absorption is slow and it continues in the jejunum and it also continues in the ileum. Okay, right? So if there's a pathology in the duodenum or the upper small intestine, it will cause malabsorption of the malabsorption of the divalent ions, such as iron deficiency, such as calcium and magnesium deficiency, and all those things. Okay. Of course, it will cause protein malabsorption and fat malabsorption as well. But if the disease is involving the ileum only and sparing the duodenum and jejunum, patient will not have protein malabsorption, patient will not have deficiency of the divalents, patient usually have a fat malabsorption. Okay, this is one of the difference. Okay, so upper small intestinal malabsorption affects everything: proteins, fats, divalents, and okay. Lower small intestinal malabsorption, which is ileal malabsorption, usually affects the fats much more than proteins. It usually doesn't affect the proteins or the divalents. Okay, so this is now how we can divide the small intestine malabsorption. Okay, I'll come to that point, but let's see the mechanism how it can happen. One is some of the diseases, they will not damage the small intestine. They will just cause deconjugation of the bile salts or the inactivation of the pancreatic juice in the small intestine, and the malabsorption can happen. Example is a bacterial overgrowth in the small intestine. Small intestinal bacterial overgrowth will cause malabsorption with normal small intestinal wall, normal small intestinal mucosa. Bacterial overgrowth is not damaging the small intestine, it is just overgrowth of the bacteria in the lumen without causing inflammation there, without causing damage there. So there's a lot of bacteria there, and they're causing deconjugation of the bile salts. So bile salts are not working. They cause damage to the pancreatic enzymes. So the pancreatic enzymes are not working. So they cause the malabsorption. So bacterial overgrowth. If there's no evidence of small intestinal damage and there's a malabsorption, this could be a small intestinal bacterial overgrowth. Okay, which usually happens in the patients who have motility problems such as diabetic autonomic neuropathy or scleroderma, or they have a surgical anastomosis causing some pouch formation where the bacteria can overgrow. Okay. Then there are diseases which actually don't cause damage to the bile or the pancreas, but they just cause coating of the mucosa. They're not damaging the mucosa, they're just causing the coating of the small intestinal mucosa. Okay, so these they act as a barrier between the lumen and the intestinal cell, intestinal villi. Okay, that happens in giardiasis. Giardia lamblia is a kite-like parasite which is quite big in size, and it causes mechanical coating of the small intestinal mucosa and cause malabsorptive diarrhea. Okay, so giardiasis is a malabsorptive diarrhea. It's not a colitis. Right? Now, then there are diseases which damage the actual wall of the intestine. Okay. One of those is a celiac disease. Celiac disease is a protein malabsorption, a protein allergic reaction to the gluten or gliadin, which causes damage to the small intestine, upper small intestine. As I said in the beginning, proteins are absorbed by the duodenum and jejunum, not by the ileum. So celiac disease, because it's a problem with the protein malabsorption, it's problem because of the protein allergy. So it involves the duodenum and it involves the jejunum. It's ileal sparing disease. Celiac disease per se does not cause ileal damage unless it's complicated by the ileocecal lymphoma. So presence of the ileal pathology in a patient with a celiac disease mean that this patient has developed ileocecal lymphoma. Celiac disease per se damages duodenum and jejunum, but not the ileum. So in the beginning, when we started, I told you the findings of the ileal pathology, like small bowel obstruction, B12 deficiency, bile salt malabsorption causing choleratic diarrhea, which causes response to cholestyramine, bowel mass formation. Okay, these are the findings of the ileal pathology. So they are usually absent in the celiac disease, unless the celiac is complicated by the ileocecal lymphoma. Okay, right? Celiac disease is a disease which involves the upper small intestine, which deals with the protein absorption. Tropical sprue, on the other hand, is an infection, okay, and that involves the whole of the small intestine, including the ileum, right? The other diseases which affect the small intestine, one of them is Whipple's disease. Whipple's is an infection, is a bacterial infection, Trophirema whipple, okay. What that causes is that is intracellular bacteria, and what it does is it stays inside the macrophages. It's intracellular bacteria which resides in the macrophages. Okay, and those macrophages, what they do is they they lie just beneath the mucosal cells in the lamina propria and some mucosa of the small intestine. So some mucosa of the small intestine is overloaded, is flooded with the macrophages which are full of this bacteria. And those macrophages, then they start traveling along the intestinal lymphatics and they block the intestinal lymphatics. And then they will block the intestinal lymph nodes as well. So what actually happens is when there's a lymphatic blockage and the lymph node blockage, that lymph starts spilling back into the lumen of the small intestine. Okay, so Whipple disease causes malabsorption by two mechanisms. One, it causes uh, it makes a barrier of the layer of the macrophages which lies between the mucosal cells and the blood vessels in the lamina propria and the submucosa. Okay, so there's a mechanical barrier. Second, it blocks the lymphatics, and lymphatics are the one which take lipids and lipid soluble vitamins from the intestinal lumen back into the blood. Okay, remember, fat hates water and water hates fat. So when fat is absorbed, that it doesn't go to the blood directly. It's not when it's absorbed by the intestine, it doesn't enter into the blood directly. It first entered into the lymphatic system, and from the lymphatic system, it goes to the liver, and then it enters the blood. That's a different story, okay? But Whipple disease causes malabsorption, plus it causes spillage of the lymph into the intestine. So lymph is rich in lipids, and lymph is rich in lymphocytes. So these patients have a lymphopenia because of loss of lymphocytes in the stool. When you're spilling back you're throwing back the lymph into the intestine, and it causes fat malabsorption and other malabsorption as well. Okay, and it causes lymphadenopathy. Then this bacteria can spread into the other organs such as CNS or the skin or the joints, and patient can have malabsorption plus extra intestinal findings of the Whipple disease, such as CNS manifestations, such as skin discoloration, such as arthropathy and other organ involvement. Okay. Sometimes the Whipple disease doesn't present malabsorption, but it just presents with the extra intestinal manifestation, but then that would present as a diarrhea. We're talking about the diarrhea, so I'll stay at the point when the Whipple disease actually present with the malabsorption, right? So malabsorption due to the small intestine is could be bacterial overgrowth if the patient has underlying motility disorders, and that is usually diagnosed if you do the endoscopy and to take a specimen of the bile or the upper duodenal and jejunal secretions. It will have a high growth of the bacteria in the colon, in the small intestine. Okay, usually happens in the patient who have motility disorders such as scleroderma, diabetes, or diverticula, or a surgical bypass such as Bilrath 1 or Bilrath 2. Okay. Uh, Giardiasis is an infection which causes coating of the small intestine and can cause chronic or acute malabsorption. Whipple disease is an infection which causes filling of the macrophages and filling of the lamina propria and blocking the lymphatics and causing lymphopenia and loss of proteins and loss of uh, lymph in the stool, and also causes malabsorption. It can cause lymphadenopathy, CNS involvement, joint involvement, or skin involvement. Okay. Then malabsorption can be a celiac disease, usually affecting the duodenum and jejunum. Ileal, it spares the ileum. Presence of the ileal findings in the beginning of malabsorption is almost always uh, very unlikely in a patient with the celiac disease. And presence of the ileal involvement in a patient who has been diagnosed with the celiac disease for some time mean now this patient has developed ileocecal lymphoma as a complication of the celiac disease. So uncomplicated celiac disease does not give you the ileal findings, which we discussed in the beginning. All right. No abdominal mass, no B12 deficiency, no bile salt malabsorption causing choleratic diarrhea, and no bowel obstruction. Okay. Then tropical Sapru is another malabsorption, and malabsorption could be because of the small bowel shortcut syndrome. For example, patient has a ischemic bowel, or the patient has a surgery of the small intestine when a lot of the length of the small bowel has been resected by the surgical procedure. So that will also cause uh, malabsorption, right? Now, we have discussed the chronic diarrhea, three patterns of the chronic diarrhea: chronic watery diarrhea, which is chronic ileal disease, villus adenoma, and neuroendocrine tumors. Then we have discussed about the chronic bloody diarrhea, which is colitis of different types: ulcerative colitis, Crohn's colitis, radiation colitis, infectious colitis, ischemic colitis. Okay. And then endoscopic histological diagnosis as lymphocytic colitis or collagenous colitis or microscopic colitis. But chronic bloody diarrhea is colitis unless proven otherwise. You have to figure out what type of colitis it is. It can't be small intestine. And chronic malabsorptive diarrhea, which is chronic bulky diarrhea having a lot of fat in it, steatorrhea, mean this is malabsorption, which could be because of cholestasis, could be because of the exocrine pancreatic insufficiency, and could be because of the small intestine. In the small intestine, it could be giardia, it could be bacterial overgrowth, it can be Whipple disease, it can be celiac disease, it can be tropical sprue, and it can be uh, short gut syndromes. Okay. Remember, celiac disease can in 40 to 50% of the cases, celiac disease can present with systemic findings without any GI findings. Okay, so absence of the GI finding doesn't exclude celiac disease, but we are not discussing celiac disease right now, so I'm not going into that detail. But certainly, celiac disease can cause malabsorption as well, right? Then the fourth type of the chronic diarrhea is a chronic osmotic diarrhea. As the name itself is explanatory, there's some osmotic chemicals in the small intestine which is causing a lot of fluid secretion in the small intestine and causing osmosis and diarrhea, right? And because there's a lot of volume, so that causes rapid movement of the food, and that adds on that make add some malabsorptive component as well. But the definitive diagnostic clue for the malabsorptive osmotic diarrhea is when the patient is not eating, diarrhea settles down. So diarrhea which settles with the fasting is chronic osmotic diarrhea. Usually the osmotic chemicals are ingested, okay, and they cause diarrhea. Lactose intolerance is one of the example. Patient can't absorb the lactose, and it acts as osmotic chemical and causes diarrhea. Okay, there's different types of fructose intolerance, lactose intolerance, and other osmotic chemicals can also be there in the diet, right? So osmotic diarrhea, and the next type of the chronic diarrhea is a chronic diarrhea because of gastric conditions. Remember, two important gastric conditions you need to understand. One is hypersecretion of hydrochloric acids. So when there's a lot of acid production, such as happen in Zollinger-Ellison syndrome, this acid is huge in quantity. Okay, so because of the overflow, it will move the small intestinal contents rapidly down and adds to the malabsorption. This is one mechanism. Second, the acid will cause acidic pH in the duodenum and in the jejunum. Normally, the duodenum and jejunum need alkaline pH for working. Bile salts and pancreatic enzymes, they need alkaline pH to work. If the pH becomes acidic, bile salts and the pancreatic enzymes become non-functional. So Zollinger-Ellison syndrome, one, it can cause flushing, rapid flow of the intestinal contents and causes malabsorption. Second, because of the high acid changing the pH, inactivating the bile salts and inactivating the pancreatic enzyme, this is how it causes malabsorption. The second disease of the stomach is Menetrier's disease, Menetrier Menetrier's disease. This is basically a goblet cell hyperplasia. Goblet cells are the cells in the stomach, normal stomach, which normally produce mucin. The purpose of the mucin is coating of the gastric mucosa to prevent the cells to come in contact with the gastric acid. Okay. These goblet cell hyperplasia, they produce lot of mucin. This mucin will overflow just like acid and will cause flushing of the small intestinal contents and will cause diarrhea. Now, both of these gastric conditions, if we put a nasogastric in and suck the gastric secretions upward rather than letting them flow downward, will improve the diarrhea. So nasogastric tube with active suction will settle the diarrhea. This is one of the clue that this is a gastric diarrhea. Okay. The second is, if it's a Zollinger-Ellison syndrome, it usually gives some response to the high dose of PPA, proton pump inhibitors. When you will reduce the acid production, it will give some response to the PPS. Thirdly, endoscopy will get the diagnosis. In many types of disease, the gastric rugae, mucosal folds, they are hypertrophic. They are very thickened. Okay. In Zollinger-Ellison syndrome, there will be presence of hyperacidity, and gastric acid production will be very high, even in the fasting condition. And there are different tests to diagnose it. Then there's a chronic diarrhea because of the systemic conditions. There's some systemic conditions which can cause diarrhea. Remember, some of the conditions, they have a direct effect on the gut. For example, diabetes. Diabetes can cause autonomic neuropathy and alter the motility of the small and the large intestine and can cause chronic diarrhea. All right. Second is a scleroderma. Scleroderma has the same problem. It damages the smooth muscles. It replaces the smooth muscle with the fibrous tissue, and that reduces the motility. They can cause bacterial overgrowth and can cause diarrhea. All right. Although the motility is reduced because of the damage to the smooth muscle, but the patient has diarrhea because of the bacterial overgrowth. All right, which will lead to malabsorption and cause diarrhea. Right. Then psychiatric problems such as depression and anxiety, they can present with the diarrhea. So systemic causes of the diarrhea. Few important conditions which we need to understand other than these diabetes and psychiatric problems and scleroderma. There are a few other conditions. Remember, staph infection anywhere in the body can affect the gut because staph produces toxins such as labile toxin, okay, and heat stable toxin. So these toxins can increase the gastric motility and can cause diarrhea, all right, and vomiting. So staph infection, for example, patient has bacterial endocarditis, so they can present with the diarrhea. Patient has staph infection, staph osteomyelitis going on for a few weeks. They can also present with the diarrhea. Okay, so staph infection anywhere in the body can also affect the diarrhea. You often have noted that because the immune system, the autonomic nervous system is not very well developed in pediatric age group, in the infants and the newborns, and similarly, it's not as good in old age. So these patients in old age and in the neonatal age group, they can have diarrhea due to any systemic illness. For example, when the children, newborns, they start having their teeth, they have diarrhea. One of the reason is, of course, they start putting everything in the mouth, but other reason is systemic irritability. All right, same can happen in old age. Then certain types of the pneumonias can present with diarrhea as well. For example, atypical bacteria can affect many other organs other than the lungs. So they can also present pneumonia as well as the diarrhea. Pulmonary tuberculosis or pulmonary fungal infections, right? They can also spill down into the lungs, into the gut, and involve the intestine as well. So one of the reasons for ileocecal tuberculosis is a pulmonary tuberculosis. Although the pulmonary tuberculosis can happen without ileocecal tuberculosis can happen without pulmonary tuberculosis, especially if it's a bovine TB, okay, but which comes through the milk injection. But pulmonary tuberculosis can also cause chronic diarrhea affecting the ileum, right? So these are the types of the chronic diarrhea. So let's summarize them. So patient comes with the diarrhea. The duration is less than 2 weeks. This is infection, infection, and infection. How does infection present? Infection can cause bleeding by damaging the colon. Infection can cause malabsorption by breaking the bile salts and the pancreatic enzymes and damaging the small intestine. Infection can cause watery diarrhea by producing a lot of toxins and which increase the intestinal secretions. Okay, so infection can present in any way, any pattern of the diarrhea. But when the diarrhea is less than 2 weeks, it is infection unless proven otherwise. If the diarrhea is more than 2 weeks, it can be infection, especially such as chronic infections such as TB and other infections. but then the non-infectious causes also comes into the play. So far, we have discussed only the non-infectious causes of the diarrhea, okay? And among the non-infectious diarrhea, we classify them in chronic watery diarrhea, which mean ileal disease, villus adenoma, and neuroendocrine tumor, chronic bloody diarrhea, which means colitis, chronic malabsorptive diarrhea, which means cholestasis, pancreatic insufficiency, and small intestinal disease. Small intestinal disease can be further classified. Is there any damage to the small intestine or there's no damage? If there's no damage, it could be bacterial overgrowth or it could be giardiasis. If there's a damage, we think about the celiac disease, tropical Supro, Whipple's disease, some short gut syndrome, and those other conditions. Okay. Then we think about the gastric diarrheas, which are either many triad disease, increased mucus production, or Zollinger-Ellison syndrome, increased acid production, which improve by the nasogastric tube and active suction, which also improve by proton pump inhibitors. Okay, and then we think about the systemic causes of the diarrhea, right? Such as diabetes causing autonomic neuropathy, scleroderma affecting the intestinal motility, stress, depression, anxiety causing increased motility problems, okay, and pneumonias and pulmonary infections, right? Antibiotic can cause diarrheas. And the last one, which is not sinister, is irritable bowel syndrome. Irritable bowel syndrome, as you all know, is one of the condition which can present with the chronic diarrhea. Irritable bowel syndrome can have a predominant constipation, can have predominant diarrhea, or can have an alternating pattern, diarrhea, constipation. So it can present in any way. But one of the classic few things which you need to make sure when you label somebody with irritable bowel syndrome is that all the examination is normal. There's no signs on examination. There's no abdominal tenderness or peritonism or bowel obstruction. Okay. Patient hasn't got any weight loss, even if the patient has chronic diarrhea, but it doesn't have any weight loss. Okay. Diarrhea usually doesn't happen at night. When the patient is asleep, patient doesn't have to wake up to go to toilet for diarrhea. Okay. All the investigations will be normal. So all examination is normal, all investigations are normal. There's no diarrhea when the patient has gone to sleep. Okay. It can be long-standing diarrhea and there's no significant weight loss. Patient may have diarrhea, chronic diarrhea for many years, 6 months, 2 years, 1 year, but there's no weight loss. What type of diarrhea is this? Okay. So these patients often have IBS. So it's a diagnosis of exclusion. Irritable bowel syndrome is a diagnosis of exclusion, okay, which means all the examination is normal, all the relevant labs are normal. We have excluded all the other patterns of the chronic diarrhea, and then we think this could be irritable bowel syndrome. It can often be associated with other psychiatric or depressive illnesses. Okay, it's more common in anxious patients, usually young patients. It's less common in older people, but it can happen. But make sure it's a diagnosis of exclusion, right? We haven't talked about the acute diarrheas and we haven't discussed the chronic infective diarrheas. Okay, all we discuss is a chronic non-infective diarrheas, right? So I rest of the things that what we find on the stool examination, if it's infection, if of course uh, we can grow some bacteria or parasite in the, for example, we can have a amoebic assessment of the stool. We can find giardia in the stool, or we Campylobacter, other bacteria culture may be positive. Fecal elastase will be high if it's alpha, if it's a pancreatic insufficiency. Okay. In the malabsorption, remember the role of the pancreas is to break, is to break, break the fat into fatty acid and glycerol to separate them. Okay. So if it's a pancreatic insufficiency, there's a fat malabsorption and the fat appears intact in the stool. So increased fecal fat with intact fat in the stool usually means pancreatic insufficiency. If the pancreatic enzymes are normal, they will break the fat. And in the intestinal disease, fat is there, but it's broken fat. So broken fat means the pancreas is working. Intact fat means pancreas is not working, as simple as that. So increased fecal fat with intact fat in the stool mean pancreatic insufficiency. Increased fecal fat with broken fat mean pancreas is okay, is the small intestine or the bile which are the culprit, okay? And in inflammatory bowel disease or any other infectious bowel disease, fecal calprotectin will be high in the stool. So stool test can help us. In osmotic diarrhea, stool osmolarity is usually higher than the serum osmolarity. And stool may be able to detect the culprit osmotic agent as well. So stool test gives a lot of clues. But what I wanted to emphasize was the clinical clues of the chronic diarrhea, right? Again, more than 2 weeks, if it's watery, pure watery, this is ileum, this is ileum, this is ileum, okay? And if it's not ileum, we have done the endoscopy, MRI, MRI enterocolisis, the ileum is normal, then this is a villus adenoma. That colonoscopy will detect it. And if it's not villus adenoma, it's ileum is normal, then it's a neuroendocrine tumor, and we need to get the blood levels and those investigations for those neuroendocrine tumor. If it's chronic bloody diarrhea, this is colitis unless proven otherwise. We have to figure out what type of colitis is. Is it a rectal sparing colitis or is it rectal involving colitis? Okay. And which part of the colon is involved? Then if it's chronic malabsorption, we classify as cholestasis, pancreatic insufficiency, and small intestine. Among the small intestine, you classify as is it giardia? Intestine is intact, it's just malabsorption. Is it bacterial overgrowth? Intestinal structure is intact. It's just bacteria in the lumen, not damaging the intestine. Okay. Uh, or is a celiac disease which involves the duodenum and jejunum, or is a tropical seborrhea which involves the whole small intestine, or is a Whipple disease which has lymphopenia, lot of deficiency of lipids in the body and malabsorption, and we can find the bacteria in the duodenal aspirate or in the duodenal biopsy in the lamina propria. Okay, and patient have extra intestinal findings as well. Then is it a what gastric diarrhea? Is it a systemic causes such as diabetes, scleroderma, and psychiatric problems? Okay, or is it a IBS? Okay, so with this I will end up here, and I'm happy to take questions. Gufran, please stop the recording now.